Hi everyone, and welcome to Alliance Live, the online information and learning portal showcasing examples of innovative and integrated working taking place across Scotland within health and social care. We continue the series of these 30-minute webinars focusing on excellence in care, excellence of care, the new nursing and midwifery standards presented by Andrew Moore, Head of Excellence in Care at Healthcare Improvement Scotland. Andrew is an adult nurse who has worked in the NHS for more than 30 years. He has held several clinical and managerial posts, spending most of his career with NHS Ayrshire and Arran. He took up post as Head of Excellence in Care with Healthcare Improvement Scotland 12 months ago. He has a particular interest in staff wellbeing and quality improvement. Finally, as Andrew delivers his presentation, we invite the audience to pose questions using the Q&A box, which is found within the toolbar up at the top of my screen, if you can see that Q&A box right there. These will make up the questions for the Q&A session, which will follow on the presentations and bring our webinar to a close. Now, without further delay, over to Andrew.
Good morning, everybody, and thank you for the opportunity to come and tell you about the Excellence in Care programme. So excellence in care is a nursing and midwifery thing, and as you're probably aware, nursing and midwifery make up almost about 43% of the NHS Scotland workforce, but I think importantly it's about 80% of the actual care delivery across Scotland. So everyone at some point in their lives will come into contact with a nurse or a midwife. And we think that's why this work is so important. So I want to start by asking a question, and I'll come back to the answer to the question at the end of my presentation. So I want to ask you a question. So what do cows and humans have in common? What do cows and humans have in common? It'd be good to see some of your answers in the text box as we go along, but I'll come back to that at the end of my presentation. So I just want to start with a wee bit of context. Why is the excellence in care work so important? There's a number of factors there. You know, there's been real systemic failings in the delivery of care. We've seen that through the Vale of Leven inquiry, the mid-staffs, Morecambe Bay, where there have been sort of individual and systemic failings of governance. You know, and obviously we don't want these things to happen again. They do seem to happen on a fairly regular basis. There's something for me also about staff well-being. We know the pressures that staff are under out there in service, and you know, every day can feel like surviving. And you know, I know personally some colleagues and teams where every day does feel like they are surviving. So we want to move people from surviving to thriving, and we know that if we look after the staff, then they're going to look after the patients, and we're going to get better outcomes from a patient perspective. I think from a nursing and midwifery perspective, we've also created a couple of monsters. So one of the monsters for me is paperwork. People are drowning in paperwork. And we've kind of set nurses and midwives up to fail in some respects around paperwork. So we have to look at rationalising paperwork and how we use nursing midwifery record keeping to actually drive care, and it's not just a retrospective exercise. The other thing for me is the whole safety, patient safety agenda. I think some of that has been imposed upon people. So it's, you know, here, apply this bundle to a certain area of care, which has really sucked the clinical judgment away from nurses and midwives at the front line. In some areas, not in all areas. So we're really keen that we ensure that, you know, as autonomous healthcare professionals, nurses and midwives are able to use their clinical judgment. The other thing is unfinished work. We know that nurses tell us all the time that, you know, they leave a busy shift not having been able to complete everything that they want to do for their patients, and that definitely has a negative impact on quality, but also on job satisfaction. And if we look at the system that we're working in, essentially we are working with broken systems and processes. You know, we have an acute model of care in the main, but we need a model a more anticipatory model that deals with multi-morbidity, and that's where we want to move to with the whole health and social care integration agenda. And the other thing we see in practice is obviously an increasing demand for services. And nurses, particularly nurses in hospitals, spend a lot of time on failure demand. So, trying to chasing stuff, repeating tasks. Some of the work I was doing recently, it was up to an hour and a half a day on failure demand. So that's time that could be spent in a patient-facing way with patients. So that's a wee bit the context. The other thing I want to mention is that, nurses, everybody, in fact, in health and social care as leaders kind of wrestle with these polarities on a daily basis. And these are really continuums, and I think it's about trying to get the balance in the continuum, between delivering operationally and transforming the service, introduction of top-down strategy and trying to take bottom-up action, the kind of structure within an organisation, and then people having some agency over what they're doing. So we know that these are polarities that people are wrestling with on a daily basis, but we know from the literature and also from people's lived experience that if you give people agency and control over what they're doing, and if you have more of an ethos of continuous improvement rather than performance, then you get much more traction around change. So we are, through excellence in care, it is about trying to give control back to senior charge nurses, team leaders and their teams at the front line, and having that ethos of continuous improvement. And again, we know from the social psychology literature that in order to get traction, the ideals have to be actionable, connected and extensible, and that's what we think excellence in care will deliver. And for us, it's not another initiative. Excellence in care is very much about a way of working. So it's not just another time-limited initiative, because I think most people out there in the service have initiative-itis. So why excellence in care? As I touched on at the beginning, it was a direct response by the Scottish Government to the Vale of Leaving inquiry. And I mean, Vale of Leaving was absolutely devastating, as you're probably well aware. 31 people died and more than 130 people suffered Clostridium difficile infection, and it was a real breakdown in care and governance. So Excellence in Care was commissioned directly in response to the Vale of Leaving, and in fact the Vale of Leaving families have been involved in the design of Excellence in Care, and some of the family members sit on the programme board for Excellence in Care, so they're very much involved. But it's about a national approach to quality management. It's about trying to get some evidence-based measurement which captures the contribution of nursing and midwifery to outcomes for patients, and that's very much within a multidisciplinary context. It's about delivering that 2030 vision, the Chief Nursing Officer's 2030 vision, which is about having a workforce that's able to meet the challenges in the future. And we want to have at-a-glance data for teams at the ward level that they can see in the one place, and that can be used from that bedside to boardroom assurance purposes. But at the core is about staff and care experience. So it is about creating the conditions where staff can thrive in terms of what they are doing, which will give us better outcomes for patients and families. So 4 key deliverables attached to excellence in care is the identification or development of a small set of measures for each nursing and midwifery family. It's the development of a document that helps with the implementation of excellence in care, and Scottish Government are leading on that, and we're anticipating that will be published towards the end of this year, probably in December time. It's about the development of a dashboard so that people have at a glance access to the information they need about the quality of the care that they're providing. And then the last thing is some record keeping guidance for NHS Scotland. I'm chairing a national group at the moment, and the first thing that we're doing is developing principles of design for record keeping for NHS Scotland, which will help those who are responsible for developing record keeping so that they're doing that in a more robust way. So that's the 4 key deliverables. And we are trying to do this across the whole of Scotland. So nobody's done this on a system-wide basis as far as we're aware. So as you know, whether it's in the big district general hospitals or one of our remote islands, we are trying to do it across the whole of Scotland. And essentially, what we're trying to get teams to get to the point is that they are talking about quality as a matter of routine, and that they have the time to talk about quality, and that management are valuing the time given to teams to talk about quality. And really, they should be able to answer this sort of key question, how do you know how good you are? And it is about, using your data to get a picture of the quality of the care that you're providing. How do you know where you stand relative to the best? Do you know where the variation sits within your data? And do you know your rate of improvement over time? And I would suggest that these are the sort of key questions for leaders. And essentially, the old way of doing quality improvement was trying to stop the bad stuff happening. But for us, we're trying to move that on, and it's very much about continuous improvement and moving that bell curve to the left. So it is that process of continuous improvement. And we do have a care dashboard. So the care dashboard is now up and running. It's called the Care Assurance and Improvement Resource, and our NSS colleagues have done an absolutely fabulous job in terms of getting the dashboard up and running. It's got good functionality. So at a glance, you can look at your measures. You can also compare your measures to other wards, and you can look at your variation because it's got run charts and the run chart rules are applied, etc. So we think it's a really good resource. It's going to pull all the quality information into the one place, which we think is important for teams. Our biggest challenge is data capture. As you may be aware, I'm sure you definitely will be aware, we have a legacy of a duplicity of electronic systems out there, and some of the measures we're unfortunately having to capture on a manual basis. But our plan is that over time we want to move to electronic data capture, so that nurses and midwives at the front line don't need to think about the data capture. But and we have a group set up to look at that, linking in with the digital strategy, etc. So we have a generic excellence in care framework, and this maps across to the HIS quality framework, so that ties in with quality of care reviews, because as we know, going forward, we're moving away from that kind of point in time inspection to something that's a bit more rounded, looking at sort of continuous improvement. So we felt it was important that aligned. And as I said at the beginning, our kind of theory of change around delivery of excellence in care is very much about a quality management approach for nursing and midwifery. And we're using the HIS quality management system as the vehicle for delivery. So that's very much about getting that balance between the 3 elements of quality management: quality control, which is about teams owning their own story around improvement; quality improvement, where we've put a lot of work into increasing capacity and capability across health boards and systems; and then quality planning. And that's a bit that we're probably light on, because teams spend so much of their time trying to deliver a service that they don't have the time to do the planning piece and the reflection piece. And we know that's really important in terms of getting ownership around quality, and also to recharge those empathy batteries, so that teams can continue to be person-centred in the approach. And that needs to then be in the context of a learning system. And then around that, you have the creating the condition elements of relationships, co-production and co-design. And co-production is a big thing for me, because I think a lot of our service is still quite paternalistic. So we have to really be working in partnership with patients so that they're setting their own agenda, etc., going forward. So that's part of what we're trying to achieve with this work. So it's quite a big investment from Scottish Government. So there's a funded national team, which involves Healthcare Improvement Scotland, NHS Education for Scotland and NSS. But Scottish Government have also funded an Excellence in Care lead and an e-health lead in each board. So we are working together to develop the measures at the moment, and most of the effort's gone into the development of the dashboard and the quality measures across each nurse family. So we have some core measures which are applicable to all nursing and midwifery families, and then some specific measures for each individual family, such as community nursing, neonatal, prison, specialist dementia, mental health, etc. So it's a big piece of work with sort of 17 working groups on the go. So that takes a wee bit of management. The other thing I want to touch on is we are keen to increase the amount of patient and public involvement that we have in our work. A lot of the measures are quite clinically focused at the moment, but we want to look more at how we can look at what patients and families want and need in terms of the quality of nursing and midwifery care. And this is just one example. So the Children and Young Persons Working Group, they were looking at their measure for school nursing, and they've held focus groups in secondary schools asking, across the whole age spectrum in secondary schools, what they would like to see from a school nursing service. And they've used that intelligence to help develop their measures. But we're not doing enough of that. I think we have to do more of that in terms of the sort of co-production piece. So I'll just quickly go through the measures. So there's as I said, there's core measures and then there's specific measures. So these are the core measures. And again, as I said, these are mapped to the quality of care framework in terms of the elements. So there's professionalism and trust. So we're looking at nursing midwifery complaints, the number of nurses and midwife with quality improvement leadership qualifications, because that's about capacity building around quality improvement, and the QIMPL score, which is the student experience of placements within nursing and midwifery settings. We're also looking at workforce measures, establishment variance, absence rates, supplementary staffing and workload tools. Looking at culture, so that's includes the IMATTR engagement index and the number of staff with objectives. We've got a couple of person-centred measures, so we're looking at the 5 must-do with me's, and in the first instance, we're looking at what matters to me. So that's about identifying people's needs and preferences, and then having a plan around that, and then who matters to me in terms of access to loved ones. We've spent a lot of time debating the person-centred measures, probably hundreds of hours. But we know that each board's at a different place in terms of where they're at with person-centred, so we kind of had to come to a compromise around where we started. So the what matters and who matters to me measure is really just a starting point on which we want to build, because we recognise that person-centred is much more than just these 2 elements. So in terms of nurse family specific indicators, these are the ones that have already been agreed, and really we've taken these ones from the patient safety programme because it kind of makes sense to look at indicators that have already been established. So we're looking at early warning scores, inpatient falls rate, pressure ulcers, medicines omission rate. We're looking at hospital-acquired infection, and in particular the screening for CPE and MRSA. And then in paediatrics, they're looking at early warning scores as well. And then from other nurse family specific measures. So this is work that's all still in train. So this is work in progress. So we're looking at nutrition, we're looking at professionalism, reflective practice and clinical supervision, because that's so important in terms of staff's well-being and recharging the empathy batteries, etc. NHS 24, they're looking at indicators. Children and young people are looking at assessment and care planning. Mental health looking at care planning assessment. Learning disability, community nursing, specialist dementia, midwifery, prison and neonates. So we're covering sort of about 95% of nursing and midwifery families there. We're also going to look at bringing on day surgeries, primary care nursing, NHS BT, other areas of nursing that we haven't quite looked at yet. So that'll all be work and train for next year. So in terms of progress and timescale, as I was saying, all the core indicators and adult, inpatient and paediatric indicators are up and running. The dashboard's now available across all inpatient areas, and each board is developing a plan to capture their data. The remaining indicators will be completed by the end of March 2020, and then we'll be looking to roll out the indicators, the measures across community settings. So we're kind of on track in terms of what we've agreed with the programme board for completion. It's also just worth saying that the measures do tie in with the Health and Care Staffing Act that was recently passed, because the quality measures will be used as part of that workforce planning assessment that staff will be mandated to undertake. So again, it's about tying that work together. And we also have a kind of 5-year plan for excellence in care, and we recognise that it's very much just a nursing and midwifery thing at this point, and we really want to. We think it really has got the potential to become a multidisciplinary approach. So where we want to get to, electronic data capture, we want that data capture to be as near real time as possible. We want to continue to demonstrate the nursing and midwifery contribution to outcome for patients. We think it has the potential to become multidisciplinary. It's very much about teams owning their own story of quality. And as I said at the beginning, it's very much about staff engagement and creating the conditions where staff can thrive in terms of what they're doing. So that's where we want to get to in the kind of key elements of the 5-year plan. And then just back to the question that I asked at the beginning. So what do cows and humans have in common? Well, this is one of my favourite studies, which was undertaken by the University of Newcastle, where they took 2 groups of cows, milking cows, and one group, they played music to them, they massaged them, they looked after them, and the control group, they just milked them as normal. And the group that was looked after were 20% more productive when it came to milk production. So I suppose the moral around that is that, if we look after our staff, then they're going to be more productive, and we're going to have better outcomes for patients. So that was really just a quick fly through the Excellence in Care programme, and thank you for the opportunity to do this.
That's great, thank you, Andrew. That brings us to the end of the presentation section and onto the Q&A portion. So the first one comes from David. What do you believe will be the biggest challenges for the 4 key deliverables? Is it making staff think more about an integrated way of working in health and social care?
Yeah, well, I think for me the biggest challenge is that because nursing midwifery teams are so focused on care delivery, that they're not really taking the time, or they're not being given the time to talk about quality as a team. So I think what the step change here needs to be is back to that, getting the balance between the 3 elements of quality management in terms of quality planning, quality improvement and quality control. We want teams to be talking about quality. We want teams to be owning their story of quality. We want the teams to be setting their own quality improvement priorities based on their data. because what teams tell us is that, you know, different bits of the health board or system come and tell them what they have to do, but actually it's better if they're in control of that and that they are setting their own priorities. So that I would say that's the biggest challenge. And then the second challenge is around data capture, because we still have a lot of manual data systems, which is quite onerous for staff, which is really just adding to the burden. But we really want to get to the point where we've got electronic data capture and staff don't have to think about that. And essentially that we should be moving towards an electronic record, you know, so that you're capturing the quality measures as part of the record keeping process and not doing it as a parallel or separate process.
Great. So third one we've got comes from Kerry. How do you ensure consistency of care across each health board?
Well, that's an interesting one. So obviously, you know, it's for health boards. You know, they are autonomous bodies, so they are responsible for the quality of the care that they provide. But part of that independent assurance check is the work that Healthcare Improvement Scotland does in terms of inspection process. And particularly moving forward, we're looking at quality of care reviews, which is that kind of looking at the whole system. So how is the system, you know, how is the health board working as a system? Do they have the systems and processes in place across the key elements of quality, so that they're able to, you know, create the conditions for staff to provide quality, a high quality of care. So it's very much health boards, you know, doing that as autonomous vehicles themselves, but as working together as a learning system and sharing good practice. Because again, you know, part of the work that we're doing is about, you know, why Scotland's a small place, we shouldn't be reinventing the wheel around good practice, and we should be able to share that good practice. So part of the work that we're doing around excellence in care is bringing people together at hub meetings. So, you know, all the health boards get together and we share the good practice, we share the work that we're doing, some of the solutions around data capture, you know, some of the other work that teams are doing. That's part of it.
Thank you. So we have a couple of questions also coming in from Twitter. The first one: how does compassion fit into excellence in care?
Well, I think compassion's right at the centre of it, you know, because it breaks my heart when I see the burnout rates amongst staff, and we know from the evidence that, you know, unless we look after our staff and we give the staff the time to reflect and to recharge their empathy batteries, then they won't be able to continue to be compassionate and person-centred. You know, so as part of this work, and it's not just a nursing midwifery thing, you know, it's bigger than that. We have to create the conditions that staff can thrive in their work, so that they can continue to provide compassionate care.
Okay, and the final one from Twitter: where does the third sector intersect with excellence in care?
Yeah, well, that's a really interesting question. So I think excellence in care has got the potential to become a multidisciplinary thing, and we're already in discussion around that. So I think we need to be engaging with our healthcare, our third sector colleagues and independent healthcare, you know, like nursing homes, etc., because, you know, I think it has the potential to expand across all health and social care settings, but we're not quite there yet. We're trying to get our house in order from an NHS nursing and midwifery perspective, but we think there's a real opportunity for us to be working in partnership across.
And the final one from Tina: can anyone see the dashboards currently?
No, not at the moment, but the plan has always been that this information will be publicly available. But we've got a wee bit of work to do around in terms of getting all the sort of quality of the data, and then presenting it in a way for sort of public consumption. But the plan is that it will be publicly available, so that anybody can look at the data that's on the dashboard. I don't quite have a time frame for that. I would imagine that's probably about a year away, but the plan has always been, and that was agreed with the Vale of Leaving families, that it would be publicly available.
Great.
Yeah.
And so we've just got a couple of people asking if they could have a copy of the slides once the...
Yeah, of course. Yeah, more than happy to share the slides, absolutely.
Great, fantastic. So that brings us to the end of the webinar. Thank you so much to Andrew for delivering the fantastic presentation and answering those questions. We hope it's provided some insight and takeaways to bring to our own work. Before we go, finally, a big thank you to everyone once again who registered for this webinar. We hope that you join us for our next one, which is during Self-Management Week on the 10th of October, focusing on self-management and mental health. More information on that will be available in the coming days. Thanks very much again for listening in.